The night shift at Cedar Creek Medical began like all the others, fluorescent lights humming their antiseptic drone, always empty except for the breathing machines and the soft percussion of monitors counting heartbeats that might not make it to sunrise. Danielle Ross clocked in at 11:08 p.m., her badge already worn soft at the edges from 3 years of the same entrance, the same corridor, the same invisible life she'd built after Ramadi. The badge read D. Ross, RN in letters so faded they looked like they might dissolve. No rank. No history. Just another night nurse in Norfolk pushing through double doors that whispered closed behind her. She moved through ICU Bay 4 with the precision of someone who'd learned that efficiency saved lives. Her scrubs were 2 sizes larger than necessary, a deliberate choice, like everything else about her presentation. Hair pulled back so tight her scalp ached, no makeup, no jewelry except the surgical watch she'd worn for 14 years and the small gold cross on a chain hidden beneath her scrubs. To anyone watching, Danielle Ross was the kind of nurse hospitals hired because she showed up, did the work, and didn't require mentoring or attention or any of the emotional labor that administrators found exhausting. She kept her head down. She never spoke during rounds unless asked a direct question. She ate lunch alone at her desk reading journals no one else touched. She was, by every measure of institutional invisibility, perfect. The patient in bed coded at 2:34 a.m. His name was Marcus Webb, 63 years old, post-op day 2 from an emergency thoracotomy for a perforating abdominal wound from a construction accident. The monitors had been steady, blood pressure holding at 118/72, heart rate in the 80s, O2 sat 96% on 2 liters nasal cannula. Then the rhythm collapsed like a building coming down in slow motion. The monitor screamed. One long wail of flat line. Danielle didn't run. She didn't call out. She moved to his bedside in 3 steps while simultaneously snapping on nitrile gloves with a sound like a gunshot in the silence, her movements already executing the calculation her hands had performed 472 times in a war zone. The code button was already being hit by the nursing assistant. The monitors were already alerting. But those 47 seconds between collapse and first chest compression were hers. She positioned her hands, heel of the right palm centered on his sternum, left hand over top, elbows locked, shoulders directly above the compression point. The angle was exactly 90 degrees. She'd learned this in a field hospital in Ramadi where the only textbook was survival and the only professor was death. Compression started. Hard. Fast. The ribs cracked slightly under her hands, a sound like tree branches breaking, necessary and necessary and necessary again. 30 compressions at 120 beats per minute. Her body moved on its own, muscle memory taking over with the certainty of a weapon firing. The 4 was already placed. A 20 gauge in his left antecubital fossa, patent and running normal saline. Danielle reached for the epinephrine without looking, without speaking, without any of the searching hesitation that characterized most code responses. 1 milligram for push. She drew it from the Pyxis in 3.2 seconds flat, the kind of speed that came from doing it 400 times before, in conditions where every second meant the difference between a body coming back and a body staying gone. Compressions, she said to the nursing assistant, her voice flat and level, the kind of calm that comes from having already survived worse. 2 minutes. Then we reassess. The attending physician hadn't arrived yet. The residents wouldn't be here for another 4 minutes minimum. There was just Danielle and Marcus Webb and the monitors that were still screaming and her hands that wouldn't stop moving. She managed the airway without waiting for someone to hand her equipment. The ambibag was on the wall in a bright red container, mask size medium already in her hand, her left hand tilting his head back into neutral position with the precision of someone who'd done this in the dark. In sandstorms. Under mortar fire. In a field hospital built from corrugated metal where the only resource was time and the only clock was a dying patient's heartbeat. Compressions. Ventilation. Medication. The rhythm of a code, each movement flowing into the next with no hesitation, no second guessing, no gap between thought and action. 18 seconds. That's how long it took Marcus Webb's rhythm to return, a weak pulse at first, barely perceptible under her 2-finger assessment on his carotid, then strengthening. Blood pressure began creeping back. 70/40. 90/50. The O2 monitor showed saturation climbing. 92%. 96%. The rhythm on the monitor was sinus, shaky but present, a heartbeat that had almost died and had been dragged back by hands that knew exactly where to grip. The attending physician, Dr. Robert Pierce, arrived 30 seconds too late. He was still pulling on his stethoscope as he entered Bay 4, his eyes moving from the patient to the monitors to Danielle, who had already repositioned Marcus, cleared the code cart debris, started a secondary 4, and begun an EKG. Her gloves were already in the trash. Her hands were already washing at the sink. She moved like a person who'd never panicked, never doubted, never hesitated. Dr. Pierce was 48 years old and had been the ICU attending at Cedar Creek Medical for 6 years. He was a good doctor, board certified, published 3 times, respected by administrators because he kept costs down and outcomes acceptable. He was also a man who'd never had to do what Danielle Ross had just done. He'd never resuscitated a patient in 90 seconds flat while incoming mortar rounds shook the tent walls. He'd never intubated someone while lying in mud. He'd never looked a dying person in the eye and known with absolute certainty that their life depended on the next 4 seconds of his hands being perfect. He watched Danielle continue her assessment, reading the monitor rhythm with eyes that seemed to be calculating depth and angle and pressure in ways that made no sense for a nurse simply stabilizing vitals. Her hands moved with a kind of economy of motion that suggested training in something larger than an RN program. Her breathing hadn't changed. Her voice hadn't wavered. She'd been calm not in the way of someone managing anxiety, but in the way of someone for whom chaos was baseline. For whom the 18 seconds of cardiac arrest had been, on some level, a familiar dance. Report, Pierce said, his voice steady, his training intact, but his attention was no longer on Marcus Webb. His attention was on Danielle. Witnessed collapse 234, she said, her voice a measured monotone. Flatline on monitor. Compression started immediately. 1 round epi at 2 minutes. Return of spontaneous circulation at 18 seconds post-code initiation. Sinus rhythm restoration with stable vitals. EKG pending cardiologist review. Secondary 4 placed. Foley secured. Continuous monitoring implemented. She didn't say, "I did this." She presented information. Marcus Webb's numbers. His rhythm. His oxygenation. The facts stripped of any personal pronoun or any implication that the reason he was still alive was the precise architecture of her hands and the neural pathways that had been soldered into her system years before she'd ever signed up to become a registered nurse. Pierce stepped closer to the monitor, leaned over the EKG paper spooling out of the machine. His eyes tracked the rhythm, the intervals, the shape of the waves. Good cardiac physiology. Clean restoration. A patient who'd been dead, actually dead, flatline dead, and who was now not dead, whose pupils were already beginning to react to light, whose oxygen saturation was climbing toward normal. The timing, Pierce said quietly, more to himself than to Danielle. The rate of compression. The hand position. Danielle was already turning back to her charting, her moment of utility completed. She logged into the EMR, her fingers moving across the keyboard with the same mechanical precision she'd applied to his resuscitation. Dr. Pierce stood in the bay doorway, watching her profile for 3.7 seconds before he left. His eyes had settled on something he couldn't quite name, the way her shoulders sat square and level despite having just performed CPR on a dead man. The way her breathing had never accelerated. The way her hands had moved with the kind of surgical certainty that didn't come from an emergency medicine textbook. The nursing assistant had already stripped the code cart, replacing equipment with fresh supplies, restocking the medications. She glanced at Danielle with something like awe written across her young face. Everyone knew the statistics. Witnessed in-hospital cardiac arrest had maybe a 60% survival rate if you did everything right. Danielle had done everything right before most people would have even reached the bedside. The nursing assistant, Emily, was 23 and had seen Danielle Ross for 3 years and had never once heard her raise her voice, never once seen her rush, never once watched her do anything that drew attention. Until tonight. Danielle finished her charting and moved back to Marcus Webb's bedside, checking his full line, adjusting his oxygen, pulling his blanket up to his chest. The bear hugger warming blanket was already humming beneath him, managing the inevitable hypothermia that came with a code. His color was returning. His lips were beginning to pink up instead of the gray they'd been when she'd arrived. She reached for his wrist and took his pulse against the carotid, feeling the strong regular rhythm beneath her fingers, feeling the body's confirmation that he was alive because she'd known exactly what to do. In the break room, hanging on the same hook where it hung every night, was her jacket. The scrub jacket from the VA, military issue olive drab, 3 years old and worn soft at the seams. Inside the lining, sewn with field stitches that had been repaired 3 times, was a patch. Faded. Barely visible if you weren't looking for it. The insignia of 1st Special Forces Operational Detachment Delta, the unit she'd served with for 12 years before the operation in Ramadi had gone wrong in ways that the Pentagon had buried along with 12 bodies and an entire classified record. Captain Danielle Ross had been officially dead for 3 years. The woman who'd just resuscitated Marcus Webb was just a nurse, just a night shift employee, just another invisible face in scrubs moving through corridors without drawing attention to herself. But Dr. Pierce was still thinking about her hands. The way they'd moved. The way her eyes had calculated pressure and angle and depth as if reading a map that only she could see. What he didn't know was that those hands had been trained by the most lethal military institution on the planet. What he didn't know was that the calm in her voice during the code wasn't nurse training, it was the kind of composure that came from having already survived the worst that war could offer. What he didn't know was that she was still cataloging exit routes every time she entered a room, still counting rounds and measuring distances, still moving like someone who'd learned that the difference between life and death lived in the space between one heartbeat and the next. But something had changed in the 17 minutes of her shift that had mattered most. The Grand Rounds Conference Hall at Cedar Creek Medical held 30 residents in tiered seating, their notebooks open, their attention fixed on the projection screen. Dr. Pierce stood at the podium with the posture of a man who had spent decades curating his authority, his voice carrying the weight of institutional approval. Behind him, a photograph of the patient Danielle had stabilized the night before filled the screen, vital signs climbing, oxygen saturation recovering, sinus rhythm restored in 18 seconds. He clicked to the next slide. An image of field trauma protocols appeared. Blood-stained text. Combat medical procedures. Procedures that belonged nowhere near a modern hospital. This, Pierce announced, his tone dripping with academic contempt, is what we call dangerous improvisation. He paused, letting the weight of those words settle into the room like sediment. The residents leaned forward. Nurse Ross here decided that battlefield triage belongs in a civilian medical facility. She bypassed established protocol. She ignored the chain of command. She played hero. His voice had dropped an octave, the tone of a man explaining a fundamental violation of order. In a combat zone, perhaps such measures are necessary. But this is not Kandahar. This is not Fallujah. This is Cedar Creek Medical in Norfolk, Virginia, where we follow evidence-based medicine, not cowboy theatrics. Where we respect hierarchy. Where we don't let individual nurses decide they know better than the physicians directing care. He clicked again. Now the slide showed the same patient, 18 hours earlier, in respiratory distress. Subtle asymmetry in the chest wall. Distended neck veins. Deviation of the trachea. The classic presentation that every resident in that room had studied. What Nurse Ross executed was a needle decompression for suspected tension pneumothorax. A wartime procedure. Appropriate for combat environments where advanced imaging and surgical teams are unavailable for 8, sometimes 12 hours. Appropriate for triage situations where you have 40 wounded and 6 functioning surgeons. He turned to face the residents directly. None of those conditions exist here. Here, we have CT scanners 50 meters away. We have thoracic surgeons on call. We have the luxury of protocol. Danielle stood at the front of the room, positioned like an exhibit rather than a clinician. Her hands were clasped behind her back. Her face was blank. She had been briefed in advance, not as a courtesy, but as a strategy. The worst humiliation is the one you see coming and cannot avoid. Pierce had made sure she understood that by calling her into his office at 6 in the morning, before the residents arrived. The residents began to shift in their seats. A few exchanged glances. Pierce smiled slightly, reading the room like a conductor reading an orchestra. The point, residents, is this: we do not elevate individual heroism above systemic order. We do not validate nurses who think they know battlefield medicine better than the physicians who trained them. And we certainly do not allow that kind of thinking to become normalized in this facility. He looked directly at Danielle. Some people confuse medical judgment with medical authority. They are not the same thing. The presentation continued for another 20 minutes, but the core message had been delivered and absorbed. By the time Pierce finished, the institutional message was clear: Danielle Ross had overstepped. She had been corrected. And anyone who thought differently should consider the consequences of questioning the hierarchy. That afternoon, at the vending machine on the 3rd floor, Danielle was selecting her coffee when two voices emerged from around the corner. Dr. Chen and Dr. Thompson, neither of whom she had met before. Did you see Pierce rip into the wannabe hero nurse during grand rounds? Chen said, his tone casual but edged with contempt. Thompson laughed. Playing soldier with someone's life. I heard she watches too many military movies. My money says she's gone by next month, Chen replied. Pierce doesn't let people like that stick around. Danielle inserted her money into the machine. The bills disappeared. The coffee cup dropped with a hollow thud. She selected her beverage, inserted another $1, and pressed the button. The cup dispensed hot water. Steam rose, and with it came the sharp scent of instant coffee dissolving into vapor. She was reaching for the cup when she heard him behind her. Not walking. Simply appearing, as if the air had rearranged itself to make room for his presence. Security might need to escort you out if you can't follow proper channels, Nurse Ross. Dr. Pierce stood close enough that she could smell his cologne, expensive, the kind that announced itself to a room before its wearer did. His voice was quiet, which made it more threatening than if it had been raised. Quiet voices were choices. This was deliberate. Do you understand me? Danielle turned slowly. Her eyes met his. For a moment, neither of them moved. Then she spoke, her voice stripped of every deferential inflection she had learned to maintain. Strange how the patient you lost yesterday died following your protocol to the letter. She watched his face redden. Watched his jaw clench. Watched the institutional armor he wore crack just slightly, revealing the man beneath, a man who had been understood, exposed, and dismissed in a single sentence. She picked up her coffee cup, the heat warming the sides of her palms, and walked past him without another word. The silence lasted exactly 3 seconds. Then Chen and Thompson appeared around the corner, their smirks vanishing when they saw Pierce's expression. The following week, during a routine chest tube insertion, everything changed in the smallest possible way. Danielle was working with a marine anesthesiologist named Gator, call sign only, as was the way with certain people. He was assisting with sedation and airway management on a pneumothorax case, routine, the kind of procedure she had performed 200 times since beginning at Cedar Creek. She was positioned on the left lateral side of the patient, ribs exposed, the skin prepped and draped. The landscape of a human body was something she could read as easily as other people read faces. She made the incision. 2 centimeters. Precise angle. 23 degrees from vertical, accounting for the intercostal space and the trajectory she needed to reach the pleural space. The blade moved with the kind of fluid certainty that came from muscle memory, from hands that had learned this procedure not in a simulation lab with plastic mannequins, but in a field hospital in Ramadi, Iraq, with actual patients who would die if the angle was wrong. Gator froze. His hand stopped moving. His breath caught. She saw his eyes drop to the incision, tracking the pattern, the speed, the anatomical precision of someone who had been trained not in a civilian medical school but somewhere darker. Somewhere where the stakes were measured in lives and minutes and the absolute certainty that you would not get a second attempt. I know that cut, he whispered. His voice was barely audible over the ventilator wheeze and the steady beeping of the heart monitor. He wasn't asking. He was confirming something his muscle memory had recognized. "Where do you serve?" Danielle didn't look up. She continued working, her hand steady as surgical lasers, completing the incision with the same unhurried precision. She inserted the chest tube, a size 36 French thoracostomy tube, the motion smooth and final. "Sure," she said quietly. Not an answer. A request for silence. A command delivered softly but with the kind of authority that comes from someone who has given real orders in real emergencies. She connected the tube to the drainage system. Air hissed from the pleural space, the sound like pressure equalizing, like balance returning to a system that had been out of alignment. Gator's hands resumed their work, but his eyes remained on her. He said nothing else, but she felt the recognition settling between them like something solid. He knew. Not her name, not her specific service record, but the fundamental truth that had been concealed beneath civilian scrubs and a night shift schedule. He had seen people work this way before. He had trained with people who moved like this. He had fought alongside people who understood the economy of motion that came from understanding that every gesture, every movement, every degree of blade angle could be the difference between a patient living another hour and bleeding out on your hands. The procedure completed in silence. Danielle secured the tube, verified the X-ray confirmation on the monitor, and documented the placement. Gator extubated the patient once the immediate crisis had resolved, stepped back from the bedside, and gave her a single nod, the kind of nod that meant everything and could not be discussed. By the time they left the ICU, the truth had been observed and filed away. And that was the moment when everything stopped being theoretical. The call came Thursday at 11:33 a.m. ETA for minutes. Full cardiac arrest en route. Delta Force Colonel inbound via military transport, vitals unstable, ongoing CPR in the field. The intercom crackled the alert twice, and Cedar Creek Medical shifted into that particular brand of controlled urgency that meant either a miracle or a body bag. Danielle heard it from the fourth-floor supply closet where she was restocking trauma kits, her hands already moving before her conscious mind caught up. 14-gauge needles. Chest tube trays. Defibrillator pads. The muscle memory of 1,000 other emergencies, from 1,000 other hospitals, in places where the power went out and the generators screamed and the only thing between life and death was what you could do with your hands in the next 90 seconds. She was heading toward the elevators when the trauma bay doors burst open and the controlled chaos began. 10 doctors. She counted them as they converged on the gurney like vultures recognizing Carrion, Holbrook, Pierce, Martinez, Chen, Okoye, Williams, Thompson, Reeves, Sanderson, and Kim. 10. All of them surgical, all of them senior, all of them with the kind of institutional weight that made residents step sideways and nurses make themselves smaller. The colonel was a mass of contradictions, military decoration visible under the torn shirt, muscled frame that suggested decades of physical discipline, face already turning blue around the lips because his lungs weren't getting what they needed. The stretcher wheels squeaked against the linoleum like a dying animal's last cry. Danielle pushed through the observation window and into the controlled storm. Nobody stopped her. She was just a nurse restocking supplies, nobody anybody cared about, which meant she could move freely in the spaces between the attention of powerful men. The monitors were already singing their desperate song, the flat line that kept catching, dropping, almost finding rhythm before flat lines again. One of the residents was bagging him, squeezing oxygen into lungs that weren't communicating back. The ventilator was on standby, plastic tubing coiled like a snake waiting to strike. "Get me imaging," Pierce snapped, his voice carrying that particular tone of someone accustomed to being obeyed. "Full chest X-ray. Fast exam. I need to know what we're working with before we crack this guy open." He was already reaching for the patient's shirt, already assessing, his fingers moving with the precision of a surgeon who'd done this hundreds of times. Probably he had. Probably he was competent in the ways that mattered in this room, which meant dangerous in the ways that didn't. Martinez was already calling for imaging. Chen was checking the defibrillator pads. Williams was drawing labs. The colonel's blue lips weren't moving. His chest wasn't rising on its own. But Danielle could see it. That subtle detail that meant everything, the way his left shoulder dropped differently than his right, the barely perceptible divot at the second intercostal space where something had punched through and air was leaking into the space between his lung and his rib cage. A sucking chest wound, old enough that the blood had dried dark, new enough that it was still killing him. Tension pneumothorax. Air was compressing his lung, collapsing it like a fist squeezing a balloon. Every heartbeat was squeezing against a pneumothorax that was getting worse with every second they spent arguing about imaging protocols. The monitors were screaming not because his heart had stopped but because his lung had stopped breathing, and his heart was running out of places to pump. She moved toward the trauma bay cart, her hand already opening the sterile package of chest decompression supplies. Nobody stopped her. The doctors were arguing. Pierce wanted imaging. Holbrook wanted to intubate first. Martinez was suggesting they get consent before anything invasive. Okoye was pulling up the patient's sparse medical history on the computer. Williams was tracking the oxygen saturation as it crept downward, 75, 70, 65, a countdown toward the moment when his brain started dying from oxygen deprivation. The fluorescent lights hummed their fluorescent song, indifferent to all of it. Danielle found the second intercostal space, midclavicular line, the exact spot where the air was escaping, the exact entry point she'd used 40 times in field hospitals under mortar fire in Ramadi, where the only imaging was your hands and your eyes and the sound a pneumothorax made when you released the pressure. Her fingers located the space between the ribs with the precision of a concert pianist finding middle C. She broke the sterile package. The needle was cool and smooth in her hand, 14-gauge angiocath, the kind that was designed to do one thing and do it fast. She didn't hesitate. The muscle memory of Captain Danielle Ross, who had trained for exactly this moment 5,000 times, took over completely. "Nurse, step back." Pierce's voice was ice. He didn't turn around. He knew. Somehow, watching the monitors and tracking the O2 sat and arguing with his colleagues about imaging protocols, some part of him had registered her presence and recognized it for what it was, a threat to his authority. "That patient is not your responsibility." The needle went in. Clean entry. No resistance. The hiss of air escaping, pressurized air from a space where it didn't belong, escaping into the atmosphere where it could cause no more harm. The sound was distinct and unmistakable to anyone who'd ever heard it, the sound of a life being saved in a single moment. She had a one-way valve attached to the needle, a flutter valve that would keep the air from coming back in. She was already taping the needle down, securing the line, her movements economical and expert and wrong in every way that mattered to the 10 doctors watching her commit the cardinal sin of practicing beyond her scope. "Stop." Pierce's hand was on her shoulder now, his grip hard enough that she felt the fingernails pressing into skin. He was pulling her backward, away from the gurney, his voice dropping to something quieter and much more dangerous than a shout. "You are practicing beyond your scope of practice. You are practicing medicine without a license. This is your last warning before I have security escort you out of this hospital and file for immediate termination of your employment." The oxygen saturation was climbing. 65, 72, 79, 85. The monitors were catching now, finding rhythm, the heart rate settling from the frantic 142 where it had been screaming. The colonel's lips were still blue, but less blue, the color starting to return to something that approximated human. The right lung was re-expanding, filling with oxygen again, doing its job. Nobody else in the room seemed to notice. They were all watching Pierce and the nurse he was pulling away from the patient like she was some kind of contamination risk. She didn't pull away. She didn't tremble. She didn't acknowledge his presence at all. Instead, she placed the tape on the flutter valve and stepped back of her own volition, her movements precise and controlled, the movements of someone who had learned a long time ago that sometimes the most powerful thing you could do was obey while making it clear you were doing so entirely on your own terms. She met his eyes for exactly 1 second, a flat stare that held nothing but absolute certainty about what had just happened and who had just saved that man's life, and then she turned and walked out of the trauma bay while Pierce's face started to redden behind her. Get him to imaging, Pierce was saying, his voice shaking now with something that wasn't quite anger and wasn't quite anything else. Full workup. Chest, abdomen, pelvis. I want to know every injury on this patient. The oxygen saturation was 92 now. The heart rate was 118, elevated but stable, the rhythm crisp and organized on the monitor. The colonel's chest was rising on its own, his lungs filling with oxygen they weren't getting from a hole in his chest anymore. The tension was gone from his face. In another hour, he'd probably be awake. In another day, he'd probably be asking questions about what happened. In another week, the faded unit patch sewn inside Danielle's jacket lining, the one she'd kept for 18 years, the one that bore the insignia of 1st Special Forces Operational Detachment Delta, was going to matter in ways that nobody in this hospital could have anticipated. But that wasn't the worst part. The worst part was what Pierce did in the next 2 hours, once he'd positioned himself as the attending of record and started making phone calls like a man with something very specific to prove. The worst part was that a man with 10 colleagues and institutional authority and the perfect cover story for revenge could do a lot of damage very quickly. Within 2 hours, Dr. Pierce had made 4 separate calls to hospital administration. The first came at 6:02 p.m., documented in the call logs later, his voice steady and professional as he explained to the chief nursing officer that Danielle Ross had violated patient scope of practice and posed a liability risk. By 7:15, he'd contacted the director of credentialing. By 7:34, he'd reached the VP of Medical Affairs. Each conversation was surgical precision, not rage, not accusation, but concern. Concern for patient safety. Concern about qualified nurses operating outside their lane. Concern that Cedar Creek Medical might face Joint Commission violations if this behavior wasn't addressed immediately and thoroughly. The reassignment order came down at 8:22 p.m. Effective immediately. Pediatric wing. Night shift eliminated. Day shift only, under direct supervision of Patricia Hamill, the head nurse who had already been briefed by Pierce on Danielle's pattern of independent decision-making. The order was framed as a lateral move, a reassignment for the good of the institution, administrative restructuring. There was no accusation. No direct threat. Just the careful machinery of institutional power grinding forward. By 9:24 p.m., her ICU access had been revoked. New policy, the memo stated. Credentialing review in progress. Restricted area during pending investigation. The language was bureaucratic, airtight, and devastating. She couldn't access the floor where the colonel lay. Couldn't check his vitals. Couldn't verify that the tension pneumothorax was being treated. Couldn't do anything but watch from the hallway while 10 doctors had argued over imaging protocols and let a man's oxygen saturation fall into single digits. The formal investigation notification arrived via email at 9:11 p.m. A routine credentialing review. All nurses underwent these periodically. Nothing unusual. Just standard procedure following recent events. They would need copies of her licensing documentation, her education records, her employment history, her certifications. All within 48 hours. Failure to comply would result in immediate suspension pending investigation conclusion. Pierce had orchestrated it perfectly. Not brutal. Professional. The kind of systematic dismantling that looked reasonable on paper and left no fingerprints. He'd positioned himself as a man concerned with patient safety, protecting the institution, following protocol. And he'd buried her before she could surface. Before she could challenge him. Before she could do anything at all. Danielle sat in her car in the Cedar Creek parking lot for 17 minutes, hands on the wheel, reading the email again. The rational part of her brain understood exactly what had happened. Pierce had used institutional architecture the way she'd once used weapons, with precision, with knowledge of where the target would break. She was being erased. Not fired yet, but isolated, restricted, under investigation, effectively neutralized. The machine was in motion. The other part of her brain was somewhere else. In Ramadi. In the conversation with a Pentagon liaison officer who had looked at her across a table in a safe house that officially didn't exist and said very carefully, "Your service record is going to be expunged. Completely." The operation went sideways. We buried 12 bodies and all the paperwork. You will cease all military contact. You will not speak of this. You will assume a civilian identity and disappear. If you surface, if you acknowledge any of this, you will be prosecuted under the Espionage Act. Do you understand me, Captain? She understood. She'd understood then. She understood now. The order had come from a Pentagon office that didn't exist, through a liaison officer whose name she'd been told to forget, in a building she'd been told never to discuss. The operation in Fallujah's Jolan district had gone catastrophically wrong. The safe house was compromised. 17 insurgents died in the firefight. 3 civilians killed in the confusion. 1 American soldier, Sergeant Marcus Webb, had taken a round intended for her, and he didn't make it out. She'd tried. She'd kept his heart beating for 47 minutes while the exfil was being arranged, but a punctured lung and no surgical capability and rounds still coming through the windows meant he died. She died that night too, officially. Captain Danielle Ross ceased to exist. Her service record was sealed. Her unit patch was the only proof she'd ever been real. The rational brain knew all this. The rational brain was also 9 years into a carefully constructed cover, working night shifts at Cedar Creek, invisible, untraceable, safe. Surfacing now meant risking prison. Espionage violations. Unauthorized disclosure of classified operations. Or worse, the Pentagon office that didn't exist would find her, and she would disappear for real this time. No civilian hospital. No discharge paperwork. Just gone. At 3:12 a.m., Danielle sat alone in Frankie's Diner on Granby Street, the only customer except for a trucker in a corner booth who hadn't looked up from his plate in 20 minutes. The white ceramic coffee cup in front of her was cold, untouched. Steam had stopped rising from it at some point, leaving a dark mirror on the surface that reflected her face in the fluorescent light. She didn't recognize the woman in the reflection. The captain who had held a field hospital alone for 9 hours under sustained hostile fire, who had kept 17 soldiers breathing when the convoy was ambushed, who had earned a call sign whispered by insurgents in marketplaces and compounds across western Iraq, the woman was a ghost. Dead officially. Erased by pen and signature and classified decree. The nurse in the reflection was someone else. No one. A woman with a name and a social security number and a scrub uniform, but no history, no purpose, no identity that meant anything. The kind of person who could be reassigned. Fired. Investigated. Buried. Her phone buzzed at 3:02 a.m. A text from an unknown number, but she knew the sender the way she'd learned to know things in Ramadi, by instinct, by pattern, by the muscle memory of survival. 3 words, Colonel still coding. She stared at the message for 90 seconds while the coffee turned colder and the trucker turned another page of his newspaper. The choice was simple and impossible. Stay invisible, stay safe, stay erased. The Pentagon office didn't exist and wouldn't look for her if she stayed quiet. Pierce would succeed. The colonel would die or survive without her, but either way she would remain a ghost, drinking cold coffee at 3 a.m., alone. Or surface. Acknowledge that Captain Danielle Ross was real. That she was inside Cedar Creek Medical. That she was willing to risk everything, prison, prosecution, complete erasure, to save a man she'd never met but recognized because she'd spent her life learning to recognize people worth saving. She paid for the coffee she hadn't drunk. $17 with tip, cash, no trace. Drove back to Cedar Creek Medical through empty streets, headlights cutting through the dark like a weapon through water. The service entrance was propped open where night maintenance always left it, a gap large enough for someone who knew how to move without being seen. Her deactivated badge wouldn't work at the main entrance. She'd already calculated that. The stairs. 4th floor. ICU. The elevator would trigger log entries. The stairwell was dark and narrow and required no electronic acknowledgement. She took them 3 at a time, muscle memory moving her body while her brain caught up, while the last 9 years of careful invisibility fell away with each step and the captain in the reflection at Frankie's diner climbed toward something that would end one way or another. Bay 12 held the colonel, monitors erratic, 2 nurses stationed outside looking exhausted like they'd been standing there for hours waiting for someone else to make a decision. The orders were clear, no interventions without Pierce's direct approval, and he was unreachable until morning rounds. Which meant he was very much reachable but had made himself unreachable on purpose, another layer of the machinery he'd constructed to ensure the colonel would code without intervention. Danielle waited at the stairwell entrance for 14 minutes until a trauma alert came through, motorcycle versus semi on I-64, incoming, all available personnel needed in the ER. Both nurses moved, called the elevator, ran for the emergency bay. She slipped inside Bay 12. The colonel's chest showed the same asymmetry. Right side expanded further than left. Tension pneumothorax, untreated, slowly strangling him with every shallow breath. The oxygen saturation on the monitor read 84% and falling. The ventilator was doing its work, but the air had nowhere to go except into the space where his lungs should be inflating. Pressure building. Pressure killing him. She pulled on gloves, found the second intercostal space, mid-clavicular line, prepped the site with alcohol. The needle was exactly where it should be, a 14-gauge angiocath, standard equipment in every ICU. She knew the depth. Knew the angle. Knew the moment the needle penetrated the pleural membrane because of the hiss, that specific hiss of air escaping under pressure, the same sound she'd heard 40 times in Ramadi in places that had names only on classified maps. The colonel's oxygen saturation climbed. 84. 88. 91. Color returned to his face like someone had switched on a light. 45 seconds. That was all it took. Just 45 seconds and muscle memory and a decision to surface. She was disposing of the equipment when the bay doors opened and Dr. Pierce walked in, flanked by 2 security officers. His face was white, the color of someone who had just realized that the machinery he'd built so carefully was about to turn on him. But that wasn't the worst part. That wasn't the part that made everything change. The worst part was that the colonel's eyes opened, eyes that should have been closed under sedation for 18 hours, and locked onto Danielle's with the sudden, sharp focus of a man who recognized her in ways that went deeper than faces or names or 9 years of invisible identity. The sedated patient in bed 17 opened his eyes at 6:24 a.m., exactly 18 hours after Danielle checked his vitals and found oxygen saturation climbing toward normal for the first time since his arrival. His gaze moved across the ceiling, then toward the window where morning light was beginning to break through the Venetian blinds in parallel lines, and then his head turned, a movement that shouldn't have been possible for another 48 hours minimum, and his dark eyes locked directly onto Danielle's face with the sudden, crystalline focus of a man recognizing something essential. Recognition is a physical thing. It moves through a room like electricity finding ground. The colonel's pupils dilated. His jaw tightened. His breathing changed from the steady mechanical rhythm of sedation to something sharp and conscious, and when he spoke, it wasn't English that came out. Arabic, pure and deliberate, the words moving through the ICU air like a blade, Al-Malak al-Aswad. The Black Angel. The name hung there. The machines around his bed continued their rhythm, ventilator wheeze, heart monitor beep, for pump click, but Danielle felt the world narrow to the space between his eyes and hers. No one else on the floor would recognize those words. No one else would understand that insurgents in Ramadi had whispered that name in the dark after a 23-year-old army captain held a field hospital alone for 9 straight hours while mortality rounds hammered the building outside. No one else would know that the Black Angel wasn't a title she'd chosen. It was a ghost story. And ghosts weren't supposed to exist in Cedar Creek Medical in Norfolk, Virginia, with hospital ID badges and scrub uniforms and lives that involved filing paperwork and attending mandatory safety trainings. The colonel's breathing accelerated, not panic, something else entirely. Recognition mixed with something that looked like the kind of relief that comes when you realize the person you thought was dead is standing 3 feet away from your hospital bed. Danielle turned, moved toward the door without expression, her face locked in the composure that had kept her invisible for 3 years. Behind her, she heard the colonel try to sit up, heard the complaint of bandages and healing bone, heard his voice crack slightly as he tried to speak again in English, "Captain." But she was already moving through the doorway into the corridor, her badge clipped to her scrubs catching the fluorescent light, her heart rate elevated but her expression neutral, because this was the moment when everything changed and she had no idea what came next. A Marine Corps liaison was standing at the nurses' station reviewing casualty reports when he heard the colonel speak Arabic. His name was Holloway, and he'd been decorated 3 times, and his eyes snapped up from the clipboard when those words traveled down the hallway. He set the papers down with deliberate precision and looked directly at Danielle as she passed. Then he stood, walked to the break room, opened her locker without asking, and pulled her jacket from the hook where she'd hung it 3 years ago on the night she checked in for her first shift. The fabric was faded now, worn at the cuffs. He laid it across the break room table, found the seam along the interior lining, and ran his fingers across the stitching until he felt the shape beneath the cloth. His jaw tightened. He reached for the scissors on the counter, cut carefully through the stitching, and withdrew a patch so faded that the colors had nearly disappeared into gray, the first Special Forces Operational Detachment insignia, sewn there by hands that understood what invisibility meant, what it cost to disappear entirely and walk among civilians as if you were nothing more than they saw. Holloway didn't ask questions. He simply held that patch in his hand and walked directly to the administrative conference room where the credentialing committee was reviewing the latest hospital investigation. The chief medical officer looked up from her notes. The hospital attorney was there. The director of nursing. Holloway placed the patch on the table like evidence in a trial, and then he picked up the secure phone on the wall and made a call to a Pentagon office that officially didn't exist, using a verification code that accessed files so classified that even the hospital's legal counsel wasn't allowed to see the titles. Within 45 minutes, a verification officer arrived, a man with the bearing of someone who'd spent 2 decades behind desks that contained the country's most dangerous secrets. He carried a folder marked with classification headers that made the hospital lawyer pale. He opened it. He began to read. Captain Danielle Ross. Silver Star for Valor during Operation Phantom Fury, 17 enemy combatants neutralized while providing emergency medical care under sustained. Dr. Pierce appeared in the doorway. His face had gone the color of hospital walls. His voice came out shaking with something that wanted to be rage but sounded more like a man watching his last gamble fail. This is fraudulent. Impossible. That woman has no military background, no classified training, she's just a nurse who, the verification officer continued reading without stopping, his voice never rising, never changing inflection, under sustained mortar fire over a 9-hour period while operating alone in a Category 5 combat zone. 2 of the patients she treated went on to serve an additional 4 years of active duty. 3 others survived injuries that produced a 95% mortality rate in the theater at that time. Her actions saved an estimated, he turned the page. Saved an estimated 18 to 23 lives during that operation, including that of then Major James Garrett, now Colonel James Garrett, currently under care at this facility. The room went still. The kind of still that happens when certainty collapses. When the world reorganizes itself around new information. The chief medical officer looked at Dr. Pierce with the particular expression of someone who has just understood that a threat she'd believed was external was actually built into her own infrastructure. The hospital attorney was already reading something on her phone, her face going paler with each line. Holloway stood near the window, watching Pierce with the eyes of a man who understood that certain moments don't require action. They just require witness. The verification officer closed the file and placed it on the table with a sound like a door closing permanently. The investigation launched by Dr. Pierce has been thorough, he continued, his voice smooth as concrete. Perhaps too thorough. The credentialing committee audited all recent cases flagged for review, including Dr. Pierce's own surgical logs. 12 patient charts show post-operative alterations. Complication rates misreported. Surgical errors attributed to resident physicians who were never in the operative theater. A pattern spanning 18 months. Pierce's attorney was already calling him. The chief medical officer had picked up her phone. The hospital lawyer was on her feet, walking toward the door with the expression of someone who needed to make several calls before the day was over. Within hours, Pierce's surgical privileges were suspended pending formal review. By end of business, his hospital credentials were revoked. By end of week, the state medical board had opened a formal investigation. The nurses who'd worked his cases came forward one by one, statements they'd been too afraid to make before suddenly becoming possible. The residents he'd humiliated in grand rounds testified about intimidation and falsified teaching records. The Marine anesthesiologist who'd recognized Danielle's combat-trained precision during that chest tube insertion submitted a written account of negligence in the operative theater, of errors concealed, of patient safety compromised in service to a surgeon's ego. The investigation became a cascade, momentum building, walls collapsing, his own weapon turned against him with the kind of irony that felt almost planned by someone who believed in justice as something more than theory. Pierce's attorney negotiated to avoid criminal prosecution in exchange for voluntary surrender of his medical license. It was faster that way. Cleaner. By 6 weeks after the colonel arrived in full cardiac arrest, Pierce was seen in the parking lot of Tidewater Community College, carrying a cardboard box of teaching materials toward the continuing education building. A student flyer taped to the bulletin board advertised CPR certification courses, $13 an hour, instructor, Dr. Pierce. No one had ever made the transition from hospital prestige to minimum wage community college instruction quite as publicly. No one had ever fallen with quite this completeness. The nurses at Cedar Creek Medical didn't discuss it openly, but when his name came up in conversation, they simply nodded and returned to their work, understanding that some forms of justice move slowly but arrive eventually, and that the universe has a particular sense of humor about people who underestimate quiet competence. 2 months later, the ceremony in Cedar Creek Medical's main atrium was packed. The colonel stood in full dress uniform, walking without assistance, the color returned to his face like someone being brought back to life by increments. Danielle wore her dress uniform for the first time in 3 years, the fabric still fitting perfectly, the insignia still bright enough to catch the light, the shoulders sitting exactly where they should because some things don't change even when you've been declared dead by the institutions that created you. The hospital staff lined the corridors. Nurses, physicians, residents. The same people who'd watched Dr. Pierce humiliate her in grand rounds 9 weeks ago. The same people who'd heard him call her reckless, dangerous, unqualified, just a nurse playing soldier. The Marine general pinned the Meritorious Service Medal on her chest, the weight of it familiar and strange, heavy enough to feel like something real, something permanent, something that couldn't be taken away by reassignment or investigation or the simple decision to make someone invisible. Captain Ross, the colonel said, his voice clear now, strong as it must have been before the cardiac arrest, before the 10 doctors and their protocols and their arguments over imaging. You are the finest combat medic I have ever seen. You saved my life when 10 doctors couldn't. He said it loud enough for everyone to hear. He said it like testimony. Like a man bearing witness to something he understood on a level that went deeper than gratitude. Danielle stood at attention, eyes forward, the posture automatic. When it was over, when the patient was stable, when the monitors showed sinus rhythm climbing toward normal, the attending approached her. "Where did you learn to do that?" he asked. Danielle stripped off her gloves, tossed them into the red biohazard bin. The sound was clean and final. She met his gaze, and when she spoke, her voice had changed, no longer tentative, no longer the voice of someone apologizing for existing. "Power is not a title," she said quietly. "Power is the ability to help." She walked past him toward the supply cart, and in that moment, the transformation was complete. The nurse had become captain. The invisible had become visible. The ghost had walked out of the machine and demanded to be real. Her ghost status, officially ended by the Pentagon verification officer's reading of classified commendations, was nothing compared to what she'd always known, that the quietest person in the room was often the one holding it all together, and that some kinds of heroism don't come with uniforms or recognition until the moment when they absolutely have to. If this story hit you, if you see yourself in Danielle's quiet strength, if you've ever been underestimated by someone who didn't know who you really were, subscribe now and hit that notification bell. Comment below and tell me, would you have saved the colonel, or would you have walked away? What would you have done in her position? And if you haven't watched the earlier segments of Danielle's story, go back and watch how she got here. You'll understand why power isn't a title. It's the ability to help when it matters most.